Rapid sequence intubation, or RSI in short, is a technique of intubation where we follow sequential approach to achieve rapid control of airway while minimizing the risks of regurgitation and aspiration of gastric contents. We also call it rapid sequence induction and intubation. This technique aims to minimize the time between administering anesthetic drugs and securing the patient's airway. RSI was originally described in 1961 by Dr. Brian Selick. His method is now referred to as classical RSI. Classical RSI begins with gastric decompression via orogastric tube placement and removing it immediately. This was done to reduce the volume of gastric content that can cause aspiration. It was followed by thorough pre-oxygenation to maximize oxygen reserves. Patient is then positioned supine with slight head-down tilt to leverage gravity in preventing regurgitation. Anesthesia was then induced with weight-based dosing of drugs like thiopental or volatile agents, combined with fast-acting depolarizing neuromuscular blockers such as succinylcholine to achieve rapid paralysis. The Selick maneuver, or firm cricoid pressure, is applied before the loss of consciousness and maintained at 30 newtons of force to mechanically occlude the esophagus against the vertebrae. The aim is to prevent gastric content from leaking into the airway. Endotracheal intubation is then performed immediately upon observation of succinylcholine-induced fasciculations. Direct laryngoscopy with curved endotracheal tube is used for intubation with cricoid pressure is still applied. The defining feature of classical RSI is the avoidance of positive pressure ventilation between induction and intubation to prevent gastric insufflation. The entire sequence is executed as a single continuous process, typically completed within 60 seconds from drug administration to confirmed tube placement.